Hello, everyone, and welcome to Ardexia Insights. I'm Dr. Aditi Joshi, and this is where we cut through the hype to explore healthcare innovation that actually works. Each episode, I talk with the leaders and practitioners navigating digital transformation, telemedicine, AI, RPM, whatever, you name it, and system change. We share real stories from the trenches and practical strategies for creating healthcare change people can trust. So let's dive in. I'm very happy this episode that I have a colleague, Dr. Lloyd McCann, who is calling in from New Zealand. Dr. McCann is the Chief Executive Officer of Tamaki Health in New Zealand. He's a fellow of the Royal Australasian College of Medical Administrators and Health Informatics New Zealand, a former infantry and reconnaissance officer in the New Zealand Army, and a member of the expert panel that reviewed New Zealand's health and disability system from 2018 to 2020. He previously served as the Global Medical Director for Harris Corporation Healthcare Solutions and completed fellowships at Oxford University Hospitals in emergency medicine and performance improvement. He's an advocate for equity and value-based digitally enabled health and social care. He's a founder of a startup. And I was introduced to Lloyd through a Connect network in New Zealand when I asked about their virtual care programs, as I saw that they had started a countrywide program. So thank you, Lloyd, for being here with me today.
Thank you very much, Aditi. Pleasure to be here.
So I'm really excited to get into it and just really hear about your experience in New Zealand. And I'm going to start with the part of medicine where you were actually in the New Zealand Army. Since you said you were an infantry and reconnaissance officer, and then you moved into medicine and health system leadership, which is, unusual. A lot of the military doctors I know either stay in the military or they go into teaching hospitals. And so what did you find in the military leadership? What did it teach you about health system transformation that medical training or conventional medical training did not?
Look, it's a great question and great consideration. I think there are many things my time in the New Zealand Army taught me, things I apply on a sort of day-to-day basis from a practical or functional leadership perspective. But at a sort of more macro level, sounds quite obvious, but I really learned the importance of leadership in the military, seeing what good leadership does in terms of being able to complete missions, but also take in people factors, team factors in relation to how that mission actually gets accomplished and achieved. And then I think something which I've certainly held on to working across different health systems, we often talk about bureaucracies as entities or organizations that are unable to be agile, innovative, and effectively manage change. Armies around the world, militaries around the world, defense forces around the world are big bureaucracies. And I guess my experience through the New Zealand Army was actually one where good leadership drove a lot of innovation and managed a lot of change very effectively. And so I've always held on to that belief that, again, through enabled and empowered leadership, you are actually able to drive change through bureaucracy. So I've worked in the public health system in New Zealand. I've worked in the NHS, and I think through, my time in some of both of those systems where we were able to, again, through empowered and enabled leadership and having a sort of good plan, drive effective change and transformation and innovation. And then the last thing I think I'll say, just in relation to lessons from the military and application in the healthcare context is, absolutely, as I alluded to briefly just then, the importance of having a plan and then acting on that plan. So I think, we're very good in health at developing strategies and sort of defining the problem state, and then in some instances actually coming up with a plan, but we don't get granular enough. We don't take people on the journey enough in terms of an understanding of how that gets implemented. And so, it might seem somewhat paternalistic, but actually step 1, step 2, step 3, step 4 is outlined over here, and this is what we're actually going to do. And once you've got that plan actually implementing, going on time, there is a saying in the Army, an 80% plan delivered on time is much more effective than a 100% plan delivered late. And I think there again, just that willingness to act once you've got a good plan in place is something that I've certainly carried into my leadership journey in health as well.
So bureaucracy isn't always a bad word. And what I find curious, because when we think about the military, and I will say this from someone who's not been in the military, but when I speak to them, there is this, top-down approach. And so if you wanted to innovate and you wanted everyone to adopt a technology, so let's say in a hospital, it would happen, right? Because in general, the way that it's structured, there is that hierarchy, which doesn't always translate when you're outside of that. And now I know that you are in a startup space. How do you see that difference? And are there any
Yeah.
lessons that you took from that that actually helped with that digital innovation and adoption that you think that other people can benefit from?
Yeah, again, a great consideration. And I think there is something around the traditional military model, like you say, of command and control. I think the New Zealand Army was actually one of the early adopters of a slightly more decentralized leadership model, where in essence, part of the training and the understanding and the ethos was actually any person sort of in the field needs to have a good understanding of the mission, the purpose, and the why behind things, so that given the way kind of modern warfare has developed, they're able to make good decisions in the moment without necessarily referring back to, their chain of command. So I think that there are some subtleties and some nuances now that has spread across other militaries, lended itself to a slightly more decentralized approach. But certainly I think that sort of paradox around startups, my experience running a startup and the agility required and that type of thing has enabled me to kind of mesh those two things together. So, again, it might seem like a bit of a throwaway, but you've got to do both, right? I think you need a plan, you need leadership engaged, and then you need to kind of have a bottom-up build of these things so that you're able to execute something that everybody buys into and believes in, but also has a very good understanding of, like I say, not only the why, but the granularity of the steps that you need to take to implement. So I think, again, unfortunately for leaders of systems and people wanting to do some good work in this space, there isn't a shortcut around this. You need to consider the macro, you need to consider the micro, and you need to lead across all of those levels, I think, given the complexity of health and health being a complex adaptive system by definition.
I agree. I mean, we as physicians also always tell people there's not necessarily shortcuts. Even if, we find a blockbuster drug that works, you still have to take it regularly and watch yourself. So this happens in health systems as well. That's a great transition because when, you were also involved in the New Zealand's entire health and disability system and a revamping, looking at that. And so when you were looking at that, talking about looking from these things that you learn in both of those systems, how did it affect and what did you look at when we think about healthcare and health system design?
Mm.
Because I'm always curious when people go into government systems where they're going in to change something, there is always programs that exist. Your role as someone who is innovating this and then trying to get that in between what actually can happen. So I'm just curious, how do you design it? And how well did it work within the New Zealand system?
Yep. Look, the first sort of comment I'd make is it was a luxury to have that experience and that time. And I think about the other folks I was invited to come and kind of do this work alongside. So just the fact that, the government of the day said, like, actually, let's take some time out and let's resource this review, quite a huge thing. And I know other countries have done similar things, but to kind of have that is quite a luxury, because I think one of the other challenges, obviously, in health is that, we can't necessarily go close the doors, give us 6 months, we'll be back and we'll have everything kind of sorted out, right? There's the requirements around business as usual. So I think with that mindset and that frame, this was the first opportunity for a group of people to kind of actually consider the system as a whole. And that's the first observation I certainly had through that lens and through that view. One of the things I don't think we do well in health is design. And so the notion of the system kind of being designed and then developed and built was certainly not the New Zealand experience. Our system has evolved into what it is now through a series of decisions, accidents, mishaps, serendipity, decisions around funding, etc., etc. Then actors kind of within the broader system have responded to, some of those signals. So the notion of considering, okay, how do we design for consumer centeredness? How do we design for equity, which we might talk about as well. How do we design for optimized clinician experience? How do we design for technology enablement, et cetera, was just something we kind of haven't done, right? It's like we know people get sick, they need access to a primary care practitioner. The traditional model is then that referral into secondary care occurs, and that's kind of the sort of end of it. There have been pockets where I think we have tried to be more deliberate in relation to managing pathways or kind of more holistic care being provided for individuals. And that's something, again, a number of health systems kind of do very well, the curse of pilotitis. So we'll do a pilot in this area and demonstrate that works very well, but then have this lack of ability to kind of scale that up to a system level. So yeah, with that kind of observation and I think acknowledgement, how we embed and I guess develop capability around system thinking and system design is something I think any system, any good system needs to consider and then try to do. And certainly, like I say, we haven't done that here. In terms of how things are sort of rolling out post that review. So the fascinating thing, I guess, with this stuff is, again, the question around translation from sort of strategy or policy into execution. So we ended up with a broad suite of recommendations across a number of different areas. Some of those recommendations were followed kind of down to the letter written. As is the case with many things, there were others that were not followed, and there were some significant changes. I'll pick on sort of one of those. There was a consideration, again, within New Zealand that because there is geographic diversity and then population diversity kind of according to those regions, that you take a regional approach to kind of system organization and configuration. Where we ended up was actually more akin to the NHS model, where a decision was made, actually, we're going to create a national organization, create significant centralization around decision making, and again, some good thinking and reasons behind that, to have consistency in terms of service delivery, more consistency in terms of funding decisions and that type of thing, and then drive kind of down from the center, given, some of the thinking. We are a population of, over 5 million people, just over 5 million people now. So you should be able to kind of do this. What's occurred in practice, of course, is that that's just slowed decision making. Funding isn't getting to kind of where it needs to get to. And so we've now pivoted, and we're kind of going back to a slightly more devolved and decentralized structure. Again, from a system design perspective, we know that actually, lesson from the military, if you can devolve decision making as close to the clinical frontline as possible, actually you're probably more likely to achieve better outcomes for your patients. So yeah, that's a fascinating lesson, I think, in translation, change of plan, and then to I think the system's credit and the people leading the system's credit, pivoting back the other way now to that more devolved structure.
And you said a lot of really interesting things in there. And one thing I just wanted to harp on was that when you're talking about the health system design, there was this opportunity in New Zealand, like you said, to actually try that out and do it. And it also occurs to me, and this probably happens to you a lot, and I know that as people from the US, we do this a lot. We just assume if a country is smaller, with a smaller population, that these things end up easier. But the reality is you're complaining about a lot of the same things, where there
Yes.
are still regional differences, the reimbursement ends up being different, and then trying to be able to implement it and get everyone involved still ends up being the problem, regardless of the size, geographically, or the size of your population. And so all of these tools and these systems design thinking, like you're talking about, have to be considered everywhere. But that's really interesting as well. And you talk about value-based, digitally enabled health and social care with your company at Tamaki Health. And so I just want to know, when you're talking about that value to patients, how is this either in line or just even a little bit different from what all of these national programs that have been built?
Yeah. So look, I think there are a few things, again, from an enablement perspective, that we're very lucky to have in New Zealand. So one of those I'll mention very briefly before I talk about some Tamaki specific initiatives is we have a national health identifier, the NHI, and that is a unique identifier that's tagged to every person in New Zealand. So even if you're a visitor to New Zealand, you'll have a temporary, and you need to interact with the health system, a temporary NHI will be assigned to you. Everyone that's born in the country or becomes a citizen in the country, permanent resident, has this number ascribed, and that's a very, very great piece of infrastructure that we leverage, across the system. Tamaki, so we're a primary and community care organisation, 52 clinics across the country, service an enrolled population. So those are patients that are registered with our general practice entities of around 350,000 people. But we also have an urgent care, which is a community emergency department for all intents and purposes, urgent care kind of front door. And then we have a large wellness support team that enables integrated primary mental health care service delivery at a community level. Part of our strategy is a heavy bent towards looking at and understanding what digital technologies and solutions might offer to our patients and to our workforce. And then the chamber we have is targeted innovation, because we don't have, endless buckets of money. Also, we've got to be pretty targeted in terms of what we actually deploy to ensure that it has a positive impact and makes a difference to our patients and our team members. I think one of the key enablers we have as a primary care organisation, which is a little bit different to the rest of New Zealand and a number of other Asia-Pac countries, is we've got a single instance of our practice management system, or EHR, electronic health record, that operates across the network of clinics. So we're able to aggregate patient data and information, analyze and interpret that in terms of who is at risk of what, etc. But also, very importantly, then that creates a very great foundation for some technological innovation, because we've got that single instance. So some of the work we're doing, we're obviously very proud of, and there's a kind of range of things. We kind of operate across a three-dimension innovation framework. So Dimension 1 is optimize the status quo. Dimension 2 is be expert at managing transitions. And then Dimension 3 is build for the future, which is kind of reimagining what healthcare service delivery looks like. And if I talk about Dimensions 2 and 3 predominantly, so some of the work we've done in Dimension 2 relies on heavy automation being done between our digital and operational teams. And this stems from a number of back office processes in terms of how we onboard people, create user accounts, usernames, etc. That's literally saved teams tens of thousands of hours in terms of their work outputs, but also some patient-facing interventions that has meant we've been able to drive things like immunization rates up significantly in our at-risk populations. We've been able to drive HPV screening up in relation to our female patients. We've been able to drive rates around cardiovascular disease risk screening and assessment up as well, because we've again leveraged that single instance database to prompt our human operators, but also kind of take some of that mundane, things like recalling tasks, identifying the at-risk population, etc., off the workloads and workplates of those human operators to make sure things actually happen and happen in a timely manner. In Dimension 3, then, we're starting to, I guess, again, leverage that single instance database and play in the artificial intelligence space. So we've rolled out at an enterprise level an AI scribe. I know, that's not necessarily that innovative, but we've got a 90% adoption rate in terms of the use of that AI scribe. Our telehealth teams are using that AI scribe as well in terms of their interactions and consultation with patients. And we're, again, leveraging that intervention, which, like I say, is kind of becoming a BAU tool to then drive additional efficiencies in terms of clinician workflows around the generation of referrals or, a patient clinic note, etc. And I think through some work that we'll do this year, we'll again utilize that as a platform to push into the space of creating an AI clinical companion for our teams that in essence becomes another member of the care team that can potentially interact with patients, but probably act more as an assistant to our docs and nurse practitioners in the first instance.
So I'll say first, 90% adoption is unheard of. It is almost impossible to get people, at least continuously, to use it. So there has to be something that is working and has taken into what people actually need. It was one of my first thoughts. But then second, when you're talking about having this access to the data for everybody, Reminds me of, a story I heard in Finland when they've been having this access to their medical records like this for decades. And because of that, they actually started changing the epidemiology of risk factors for surgery or when they take certain patients for surgery as an example, because they have that data. And so it'll be fascinating to see what you guys are able to do as you're able to leverage the AI, these algorithms, the data that you're gathering, because not only is it everyone in the country, you're geographically isolated, right? People can still enter Finland, but there's no way to just enter New Zealand. And so that would be really interesting to see how that data is really useful and for the entire population, the population health. And but when you're looking at New Zealand and Tamaki Health, what's the transformation you're most excited about? It could be as mundane or as large as you can think. What is it that you think you're genuinely delivering value for the communities and for the country?
Yeah, look, it's a great question, and the reason I smiled is I do have a reputation for kind of being enthusiastic about everything, right? So I know that's somewhat annoying to family at home because it gets a little bit tiring. But no, look, I think we're, like I say, in a number of ways, yes, we've got our challenges, but I think we're pretty lucky in New Zealand in a number of different ways, having an NHI reasonably stable, geopolitically, all of that good stuff. We do have challenges around health. I think as a system, the outcomes that are getting delivered for patients generally remain very good. But yeah, there are creaks in the system, and that was one of the reasons for the health and disability system review. If I bring it back to Tamaki specifically, though, look, I think I am most excited by the opportunity the organization has really embraced around executing sort of on our plan, and the fact that digital is really baked into that plan. My experience across different health organizations hasn't always been like that. And, I've read a lot of what you have written about just in terms of that adoption and some of that resistance to change and all of the good reasons that go for that. There is something quite unique about, I guess, the kind of DNA from a Tamaki perspective where people are kind of bought into the why behind the reason to look at these technologies and adopt some of these approaches to ultimately transform the way we deliver care. And I think one of the key drivers for that is we seem to have gotten the balance right around, yes, there's a lot of benefit from a patient perspective that is to be gained, and absolutely we're motivated by that. But we've been able to demonstrate to our teams that actually there's quite a bit in this for me as a clinician or as an administrator, and that the benefit has been tangible. So yeah, I'm excited by the fact that we're in a relatively good place, and I know this will ebb and flow just around people kind of sort of being bought into that. And then obviously there's some very cool tech that's here now as well as on the horizon that I think we will increasingly look to leverage.
I don't think there's anything wrong with being optimistic, and I agree. There's so much exciting work to be done. It's still a lot of new things that we can use. And one day I will make it down to New Zealand. It is on my dream list, and hopefully I will get to see it in person. And I want to thank you for joining me, Lloyd. It was so interesting, all of the things about New Zealand and hearing about the journey there in digital innovation. So thank you.
Thank you
And
for
thank you
the
for everyone
opportunity,
for
Jane.
listening. Awesome. And thank you for everyone for listening to us at Ardexia. If this conversation sparked ideas about your own healthcare innovation challenges, follow along and hear from people all over the world who are building the kind of innovative healthcare that stabilizes society and makes patient care better. So until next time, let's keep creating healthcare change that people can trust.